Thank you very much for the opportunity to present to you today. My name is Lisa Hicks. I'm a hematologist from the University of Toronto, and I'm also the co-chair of the AZRC COVID-19 Registry Malignant Task Force. I'm speaking to you today about our abstract on risks for hospitalization and death among patients with malignant blood disorders from the AZRC COVID-19 Registry for Hematology. Patients with blood cancer are uniquely vulnerable to infections. This is partially because of the strong immunosuppressive treatments that they receive, but it's also because of the unique nature of their cancers, which affect the immune system. Because of this, when COVID began to spread around the world, there was widespread fear in the hematology community about how it would impact people with blood cancer. There were also many unanswered questions. Could we safely treat blood cancer in the middle of a pandemic? How would factors like disease status, recent cancer treatment, and pre-COVID prognosis impact COVID-19 outcomes? The AZRC COVID-19 Registry was really born of a desire to try to quickly answer some of these questions. The registry is a public-facing volunteer registry that aims to provide practitioners and patients with near real-time information on COVID-19 outcomes among patients with blood diseases. The aim of the project that I'm presenting to you today was to explore the independent impact of cancer treatment, disease status, type of blood cancer, and other key variables on COVID-19 mortality and hospitalization among patients with blood cancer. The data that I'm presenting today was collected between April 1st, 2020, which is when the registry opened to accepting cases, and July 2nd, 2021. I'll be presenting a multivariable logistic regression, which explored associations between mortality, hospitalization, and 8 patient and disease factors. The sample size for this data set is 1,029 patients with blood cancer and COVID-19. This makes this one of the largest data sets of patients with blood cancer and COVID-19 that's been reported to date. Our estimate for mortality in the entire cohort is 17%. In univariable analysis, older age, male sex, having active blood cancer, type of blood cancer, receiving blood cancer treatment in the previous year, estimated pre-COVID prognosis of less than or equal to 6 months, and foregoing ICU admission in favor of palliation were all significantly associated with a higher risk of death. In multivariable analysis, the results were somewhat different. Only 4 variables were independently associated with an increased risk of mortality among patients with blood cancer and COVID-19. These variables were advanced age, so specifically age greater than 60 years, male sex, an estimated pre-COVID prognosis of less than 6 months, and a decision to defer ICU care in favor of palliation. All of these variables were also independently associated with an increased risk of hospitalization with COVID-19, as were the presence of major comorbidities, having active blood cancer, having received systemic treatment in the previous year, and an estimated pre-COVID prognosis of less than or equal to 6 months. So what can we conclude from this data? First of all, I would say that it does appear that patients with blood cancer are likely at higher risk of dying from COVID-19 than are members of the general population. We report an overall mortality rate of 17%. The case fatality rate for COVID-19 among the general population in the United States has been estimated at between 1.6 and 6.2% at different time points in the pandemic. Of course, we can't directly compare these numbers. Our data is pulled from many different regions around the world, as well as from many different time points. But it does appear that the numbers, the mortality we report and the mortality reported in the general population do appear to be substantively different. Second, among patients with blood cancer, older age and male sex are both independently associated with a higher risk of mortality from COVID-19. Third, in our analysis, receiving cancer treatment or having active blood cancer, as opposed to being in remission, does not appear to be associated with increased mortality from COVID-19. And then finally, the most powerful independent predictors of increased mortality in our analysis were an estimated pre-COVID-19 prognosis of less than 6 months and foregoing ICU in favor of a palliative approach. I look forward to taking your questions later on today. Take care.